I'm Rachel, and I'm the CEO of Reverse Rett, and I'd like to welcome everyone to today's Reverse Rett Bitesize session, which is about respiratory issues in Rett syndrome. These sessions are being brought to you through a Reverse Rett project called Rett Connect, which is funded by the Pears Foundation. And I'm really pleased to say that today we're bringing this session to you in collaboration with Rett UK. Because we think this is such an important topic, and we want to make sure that as many people as possible are hearing about this.
Yeah.
And I'm really pleased to say that we have Julie Benson, who's the Family Support Manager at Rett UK, co-hosting this session with Beth and I. Thank you for being here, Julie.
Okay. Hi, Julie. Good morning. Hi.
And I want to say hi as well to Rob, who's the CEO of Rett UK, who is also here today.
Good morning, Rob.
Morning, everyone. Good morning.
So we've had a number of bite-sized sessions already on lots of different topics, and we've been doing it a little bit differently the last 6 weeks or so. What we've been doing is we've been hearing from expert parent panels, where we have about half an hour of people talking about their experiences and then a Q&A session afterwards. And today we are speaking to 3 parents who have varied but significant experience with the respiratory issues. And the discussion today is obviously focused on people's personal experience, and it isn't intended as medical advice. As always with these sessions, if you do have questions, you can give a wave, you can put your virtual wave up, or you can put it in the chat and Beth will ask the question, or you can wait till the end. It's up to you, but we don't mind if it's an interactive session. And the only other thing is, do keep yourself on mute until you are speaking, so that we don't have a lot of background noise. We will be recording the session today, so if you don't like being on camera, please just turn it off. And I'm now going to hand over to Beth to introduce herself.
Morning, everyone. I think everybody has seen me before. Everyone is a familiar face. I'm the events coordinator for Reverse Rett, and I'm just co-hosting this session. And we're going to hand over to Julie to say hi.
Hi, thanks. I'm Family Support Manager with Rett UK, and thanks Rachel and Beth for inviting me along today. It's great to do some collaborative work together. I think it's something we all have experience of, so that's been great. Thank you. So I think it's down to me to kick off and ask our panelists if they could, and this is worded in big letters, briefly introduce yourselves and your daughters, their ages, and a little bit about your experience. So we want to produce this as a bit of a timeline. So if you sort of talk about the early days and the beginnings of any respiratory issues, that would be great. I'll start with Yvonne, if that's all right, because you're first on my screen.
Okay, Julie, thank you very much. Good morning, everybody. Really pleased to be here because this is the topic I'm really passionate about. I've probably been around the longest in this Rett scene, in that it came into our lives in about 1983. In 1985, I founded what is now Rett UK. In those days, we didn't have the internet. Little was known about Rett syndrome, and even worse, they thought that Rett syndrome was a terminal illness. We were told to take our daughter home, keep her happy, because inevitably she'd die. So that was how we were in those very early days. Things moved on. The association grew and grew and grew, which is really great. And it's still there today. It has the same ethos today that it had when I started it, which is very much centered around the parents, the family, and supporting them, and also increasing knowledge and awareness. So that's all very great. My work took me really around the world. I got involved in Rett Syndrome Europe. I'm a founder member of that. I've got colleagues and friends literally around the world now. So Claire is next week will be 41 years old. She's got one of the more severe mutations, R255X, which results in the most profound physical disability. And throughout her life, we've had many, many very close shaves, many challenges. And obviously, we picked up a lot of knowledge along the way, which I'm really happy to share. Thank you.
Thanks, Yvonne. And Melise, you're next on my screen, if you wouldn't mind.
Hi, I'm Melise. My daughter Kaylin is 14. Kaylin has had run-of-the-mill chest infections once a year since she was young, but 2.5 years ago it changed. We ended up in hospital for 10 nights because Kaylin's sats just kept dropping every night. During the day they were absolutely fine, but at night they just drop. They're treated a chest infection. They were happy that was cleared, but she still needed help with oxygen at night. So we were sent home with overnight oxygen, which she is actually still on today. But hopefully we're hopeful that her paediatric consultant will actually say we can take her off, because she is only on a very small amount. But it has taken this long due to things like COVID. He wanted to keep her on it just in case. I mean, touch wood, she's never got COVID, but you know, as a just in case. But last year we had our worst chest infection. The chest infection itself, the first week we managed at home. We took her to the hospital to get her chest checked. She got our clarithromycin antibiotics for the 5 days, and we thought she was getting better. But the next week she started with what we thought was constant seizures. Now that's just not Kaylin. You were lucky if Kaylin would have one a month. But in the first day she had 24 by the time we went up to hospital. Now I know for a lot of people that is not much, but with Kaylin that was like, you know, way more than she had. But we ended up in hospital for 2 weeks. But as the time went on, she was still having these constant seizures. But as I came to tell the doctors, it was actually dystonia leading into seizures. But the doctors were treating the seizures. So we ended up in hospital for 2 weeks. She was given rescue meds every few hours. They would help for a short while, but she'd just then go back into the same cycle until neuro advised introducing chloral hydrate, which I was very wary of because I know that's not great for respiratory. But the fact that she was all hooked up to monitors anyway made it a bit easier. And that's what actually finally broke the cycle. But we did discover it was actually the chest infection that set off this, as far as I'm aware, is a dystonic storm, obviously followed by the seizures as well. We've not had it again yet, but it does make me very wary for the chest infection that will no doubt come this year, because no one yet has mentioned preventative antibiotics. I can never remember the name properly, but no one has said, oh, let's put her on these. But that's something I'll be pushing for. We are actually in between consultants at the minute because of issues with her previous paediatrician. So we are now waiting on a new paediatrician. So yeah, but
this sounds like a really difficult series of events that you had going on there. So
Yeah.
if we can just go back a second.
Yeah.
Did you say how old Kaylin is?
Sorry, I think.
How old is she?
14.
14?
14.
Yeah.
Okay. So you've got Kaylin who is 14, and who else is in your family? Just so we have a little bit of your context.
Well, there's Barry, husband, and my oldest son Paul's 22, and then Natalie, she's just turned 22, and then Alex is 19.
I always find it very surprising that other people's children age. You know, when you hear that people's kids have got older, because I got a letter from Paul a few years ago.
No,
and I can't actually. What was it, Alex? Actually, it was Alex.
Alex, yeah, but he's
I can't actually believe that they're all getting,
Yeah.
Well, okay. What we're going to do is to keep the sequence of events going, and so that we understand all the context of all of the panelists. I'm going to move on to Sam and ask him about his family in a brief introduction, and then we'll come back round, and I will ask Yvonne Melise and Sam about, you know, your first experiences of chest infections and what the signs were. Okay, so we're going to move to Sam. And Sam, please introduce yourself. Tell us about your family and
Hi,
Lillian in particular.
it's a long one. So I'm Sam. I'm the dad of Lillian, who's 12, a really big 12. She's the oldest in our children. We've got 4 younger brothers, Laura. We've got Lewis, who's 11, so really close age-wise. He's a good benchmark of how Lillian could be in a normal world. Joey, who's just turned 10. Oscar, who's now 8 years old. And then we've got Edward as well, who's a cheeky 5-year-old. So they've all grown up with Lillian, with all of her chest experiences and issues and everything else that goes along with Rett syndrome. They're sort of really caring for her. We've had experiences where she's been on nebulized cold mice and things like that. Even when Edward was a year old, I think he was holding a nebulizer to her mouth, trying to sort of help her doing that. So really hands-on family, brothers, always sort of helping her out and doing what they can with her. It's quite a weird experience because when you consider they've got cousins who are similar ages as well that have got no concept of what all of these things are, you realize exactly how much Lillian's life sort of has educated them and changed who they probably will be and how they think about things. But she's had a really tough time with things. She's had chest issues now since around about 2 years old. She's 12 now. She'll be 13 in October. They've progressed a lot. Test is in a really bad condition. She uses BiPAP overnight with oxygen. She's been on prophylactics for 5 years since a really severe admission. She doesn't have a great deal of lung capacity on one side because of the recurring issues. They've just completely wiped away her lung capacity, and she's had a really hard one. We've nearly lost her several times due to colds, flu, other viral infections, all kinds. It just, everything seems to end up on the chest with her, and she struggles with everything now. And she's homeschooled, so we've got with her all the time, so we know exactly what's happening with her now. We can keep an eye on everything, but sometimes things can just change it literally within an afternoon from a morning, and she'll be in hospital several hours later. So we've learned quite quickly now to experience when is the good time to give the hospital a call and get her in, when's the time to call an ambulance, and when's sort of safe to keep her at home and leave her be for a little while. She's had a lot of experiences, so hopefully I can pass on a bit of some of that history to somebody today.
That's great, thank you. And I think that that's the whole point of us being here, is that while it might at first appear that we're sharing people's really difficult stories, the truth is that all people with Rett syndrome are at risk of chest infections. And some people think that there might be groups who are more prone to chest infections, but we don't know who they are. We don't know how to identify them. And so it's good if everyone who has a child with Rett syndrome or an adult with Rett syndrome can be mindful of all of this. And also, I feel like what we've learned from these sessions as well, and both the organizations know from experience, that the parents that are dealing with the really difficult end of these problems are the ones that can feed in information to people who are earlier on in the process. But where I want to go with it first is obviously things change over time for all of us who have kids with Rett syndrome. And in the beginning, kind of, Yvonne, you in particular, you'll have been aware of, well, were you? Because when Claire was little, you didn't know it was Rett syndrome. So did she have chest infections before it was identified that she had
okay.
Rett? Yeah.
So just to give some reassurance, I hope, out there, Claire has had this problem since very, very early on. Every cold went into a chest infection, to such an extent our GP, if we were going away on holiday, would send us with little powdered little phial of amoxicillin that we could make up into the, liquid. So she was on that, and she was also on a nebulizer very early on. So reassurance there. That, I mean, I hope we can go on to sort of talk about things that I really honestly believe can help, that are not terribly invasive, but which families can use. But the answer is, yeah, she's had them all her life. And remarkably, I mean, she's, going to be 41 next week, hopefully. We've been able to keep her out of hospital largely and treat things at home. It's often been very scary. But the big message I want to get out there to people also is try and get yourself a chest physiotherapist if you can. They're very rare. You probably won't get one on the community. So you might have to employ one privately, but you could possibly get that funded through one of your funding regimes, whether it's continuing healthcare or whatever else you have, because I believe that this really is one of the things that saved Claire's life. She is checked at least once a week. Her lungs are listened to at least once a week by somebody who understands and who knows what her lungs normally. And there's a lot more to it than that, but that is, I think, a really key thing.
Okay, thank you. That's really good. And moving to Melise now. So you had explained when you were describing your situation with Kaylin that she had a few chest infections, but they weren't very common. And then she went through a period a couple of years ago where it got more serious. So, but when she was little, were you aware that chest infections were a problem in Rett syndrome? Did you think she would be somebody that would be prone to them? Or, and did you have any sort of thoughts of how you would cope if they came about?
When she was young, no. Didn't know it was a huge part of Rett. She would get a chest infection each year, but amoxicillin, was good enough to sort that out. So we never really thought much about them. As I said, we didn't even notice a pattern. It was around about the same time each year, because it was just, we just knew to take her to the doctor as soon as she started with a chesty cough to get her checked. It's only been over the years, as my researching, as I'm good at, has shown that, yeah, chest problems are a lot bigger an issue, especially because of Kaylin's spine curve. Well, it's become even more so, and I think that's why things may have escalated over the last couple of years, has not been helped by her curve. So no, when she was young, I didn't really think much of it. Didn't realise it was. I mean, obviously we discovered Rett UK first, obviously, which is where I first met Beth. But yeah, it's been over the years, sort of, doing research and obviously talking to other parents that have built up my knowledge base. So yeah, I think that's really important. And like Yvonne says, actually, I would never have thought, to be honest, Yvonne, about getting someone and employing someone to do chest physio. But it hugely helped Kaylin when she was last in hospital. So yeah, I definitely agree with that. We were showing a couple of basic sort of things, but at the end of the day, I'm not professional that way,
No, exactly.
Yeah, so I think that's definitely something we'll look into, because we're in the process of the continuing healthcare application.
Good time then.
So yes, I'll be sort of saying to them about that. So thank you for that, Yvonne.
Yeah, I think we'll move to, sorry, go ahead.
So I just wanted to pick up just on one point there, that scoliosis, because that's another real biggie, a really big issue with lungs. That it really needs to be controlled, watched, because it is going to have a really long-term effect on the lungs. And I think that must be emphasized as well, as much as a chest physiotherapist is. Claire's right lung, bottom right lung, is actually collapsed and has been, I think, for a long time. And she copes with that. But it was explained by the consultant who looked at her x-rays. Oh, yes, he said, that's the scoliosis. So, you know, message out there to families, the surgery is massive, it's horrendous, but actually, you have to look at the long term. You've got to look at what, you know, what that would do to the body. And if you can, it needs to be corrected surgically, I'm afraid, often.
For lots of reasons as well.
Yeah,
For
not
lots of
just that.
reasons.
So, I mean, it really is the big one. That's, I just really wanted to come in with that because I think it's a really, really important one.
Yeah. Yeah,
So,
I agree.
okay.
But, and I don't think it's said often enough, Yvonne. So I'm glad you're putting it out there. I don't think
Yeah.
it's said. It's, and we discussed this at the Scoliosis Bitesize. You know, people
I missed
think
that
it's an
one, but
option.
yeah.
People think it's an option, and it's really not an option, is it?
Claire had surgery when she was 9 years old, when, you know, it was in its infancy. So surgery has improved dramatically now. They weren't able to correct her as well as they could now. I mean, we wouldn't let her undergo any surgery anymore, but she had that, and it was a lifesaver. There's no doubt about it. No doubt about it whatsoever.
I'm glad we made that point.
Yeah.
So Sam, I want to move to you now. So let's find out from you. Has Lillian does she have scoliosis? Has she had a surgery? And, you know, where do you stand with this? Like, when she was younger, did she have chest infections right from the beginning, or did she develop them over time?
No, she's not. Her scoliosis is different. Hers is a lot lower down. It's much lower in the back, so she's curved really far, sort of kidney area. It's not affecting her lungs in the same way that it does with most of the people with Rett syndrome. But she's at that age where things can change pretty quickly, being nearly 13. So
Yeah, puberty,
we've had a lot of warnings that, you know, just because where it is now, it's going to change or may change in future anyway.
Yeah, but she's quite big as well, isn't she? So
really
she
tall.
might
She's
have
about
already
5
done a
foot
lot of
tall, and
growing.
she's about 5 foot tall, and she's not far off, around about 9-10 stone. She has lost quite a lot of weight recently, but she's a considerable size for a 12-year-old girl. Her shoulders are as broad as mine. She's just a general quite a big person. So there's a lot of weight going on there when you consider a low tone. So the scoliosis, there's a very good chance it's going to progress significantly without any intervention in the near future anyway. It's something that we're really up on, and hopefully we can avoid that. She's in a molded wheelchair, which obviously is a great help. We've had that for 4 years now, so that's a huge difference. She's got all of her equipment at home, really good at pushing everything. She's got a personal budget to continuing healthcare, which we're not using at the moment because we don't really want anybody in the house at the moment. But we've got the funding available for private physiotherapy that we could use as well. So she's got options there to keep maintaining it as we need to when we feel it's appropriate to do. So we're in a good place with things like that to try and minimize any risk as we can. But going on to the chest infections from when she was young, she didn't really have anything when she was quite little. Started around about 2 years old. We were going on a holiday, and I got a phone call just before we were packing the car up and going out that she'd had a chest x-ray on, I think it was a spinal checkup at the time, and they said that she was showing signs that she had some sort of chest haziness in her chest. So they prescribed some, I think it was clarithromycin, said that we'd treat her aggressively, get it sorted. And then everything kicked off just as soon as we started treating that. Before I got the phone call about that, I wouldn't have known she had a chest issue. She wasn't rattling or anything in the ways that I'd have known to look out at now. No coughs, nothing that you could see visibly, but apparently she was sort of impacted within her chest. I feel that it sort of woke up something that was kind of sleeping at the time. It doesn't really make a great deal of sense. It's just the way that it seemed. It was the treating it sort of provoked it into responding to treatment and to defend itself. And then just as she's just rolled from there onwards, she was in and out of hospital constantly. At that time, that holiday we went on, she ended up in hospital with seizures. So we didn't end up with the full holiday anyway. When we came home, she's in and out of hospital constantly. She'd be in for a week to 2 weeks. She'd have maybe 4 weeks at home at most. After the antibiotics had finished, a couple of weeks on, you could see she was going downhill before she eventually got to the point that she'd go back into the hospital, treat her again, send her back home again with antibiotics, and it eventually come to a point that I'd considered that there was something else going on, and it wasn't just as simple as treating her with antibiotics constantly. So I looked into it and found out about Pseudomonas, which is a type of chest infection that's very antibiotic resistant. Generally, it doesn't really cause a problem except with patients with other conditions like CF, where the excess mucus is more of a breeding ground to it. But Rett syndrome's quite a complicated thing, and without breathing and expanding her lungs and emptying her lungs constantly, I felt that maybe it was going to give her that same sort of thing as well. So I considered that was it. So it took a lot of pressure in, and we eventually got the team at Leeds General to check her over. We've been there for so long now. This must be about 2 years in, probably, into the process of chest infections. They're quite open to listening to us as parents. So we checked that she was positive for this, which I was almost certain of. It's effectively destroyed her lungs, the ability in the lungs where it's taken effect for the years before it was tested. She ended up with a lot of stronger medication when she was in hospital to try and shift it, and then came home with the nebulized colomycin, other medications as well to try and help. We eventually got it clear, and she had a while where she was totally clear from the Pseudomonas infection, and then coincidentally the chest infections calmed down. So whether it was actually sort of underlying and making everything a little bit easier to sort of spread normal chest infections or whatever, it coincided when that went and was clear, and we had confirmation it was clear through several tests. Normal chest infections and other issues calmed down for a long while. So it's something that I do like to mention to people to always check, because in CF patients, especially where there is research with it, it's a serious chest illness for somebody to be carrying. So it's something that I think that without knowing the full extent to it and researching it with Rett syndrome, it's always worth checking and treating properly and going from there. And that's the early days with learning with chest issues, really.
Yeah.
That's really interesting, Sam. And obviously, I think what we're hearing a lot is we did the research. I pushed for this. We had to push for this. And going back, obviously things were a bit different when Yvonne was dealing with these issues. But it sounds like, as we all know that a lot of the time it's coming from the parents, and it's kind of down to the parents to really push and do that research. So I think, one of the points we had to talk about was actually what professional help support were you given at the point where you realised that chest infections are a serious issue, which I think you've all already explained that kind of moment. What help and support was available, and what help and support then actually was valuable? What was useful to you that you would then be able to pass on to other parents as, this is how to pursue, this is where to go to get that kind of help? Sorry, Rachel.
It's all right. It's just that Yvonne's got her hand up.
It was for the earlier point, actually.
It hasn't come down.
Yeah.
Oh, sorry.
Yeah.
Panicking that you've got your hand up.
Yeah. No. I'm just very keen to talk about preventative stuff as well, and I hope we'll get a chance to do that, because I think there's an awful lot that we can and should be doing. And I don't know whether there's a question just came up of any of the people had pneumonia. Did I pick that up? Right, something just flashed up there.
Who's had a pneumonia vaccination? My daughter has
pneumonia vaccination.
Has had one.
But it's only, it doesn't, it only just covers certain sorts of pneumonia. It doesn't stop you getting pneumonia, unfortunately. But yes, Claire did have that.
Yeah.
So I think preventative, when we're talking about the pre-problem stage, just going back a bit now, what I'm hearing is that nobody until the point at which your daughter is having serious chest infections, nobody has spoken to you about preventative measures.
No.
Certainly from my own experience, no. Has anybody, either
No.
the panelists or anyone else, had any experience being asked about or being told about this as a serious before the problem starts?
No. But I remember once, sorry, don't want to take this over, but really important thing, when Claire was in hospital with pneumonia, I think it was one of the registrars came round and said to me, you know, the problem is these secretions. You've really got to, he said, it's very simple. He really explained it simply, very simple to understand. If you have secretions around that are allowed to get clogged up and don't move around, they stick, they can get infected, and that's what causes the chest infection. It's a very simple thing. So preventative wise, if you can reduce them, great. If you can't necessarily reduce them, you've got to keep them moving. You've got to keep them fluid. And obviously our people, if they're in wheelchairs, they may not be moving very much, but they need to move. And if they can't move, there are devices that you can use that we've discovered over the years that are actually going to help that movement. But it's a very simple message. And that you know, these are secretions that come from, we know not why. Nobody's been able to really explain, except that if you've had a pneumonia, you're going to get more secretions. And I think if you've had many chest infections or any lung problem, you're going to have more and more of these secretions. And I think Claire's chest physiotherapist, you know, just said you've got to keep on top of the mucus clearance and stretch the lungs if you can. And there are various ways, I will explain, that we've sort of got around that as well.
Yeah.
Or we are getting around that.
I think we definitely want to come back to this area of the chest physio, because I have to say, actually, I listened to your podcast, Yvonne, and that's the first time I've ever heard the words chest physio. When I heard
this once again, when Claire was in hospital with pneumonia, so one of the messages was keep the secretions moving. The second one was get a chest physiotherapist. Yeah. Okay, I went out armed. I must have spent days knocking at doors. I literally stood outside our community hospital, outside the physiotherapy department, said, please help me. And they said, no, we can't do that. We can't give you chest physiotherapy as part of the community. So then we started our search, and eventually we found this wonderful person. My husband found her one morning when we were absolutely desperate, doing an internet search, and realized that she was just the person to work with Claire, and it's been great.
Yeah, I think we.
But it wasn't easy, and it wasn't on the NHS, sadly.
No.
Can we add this lady is Sian Midwinter, who's your chest physio?
Sian, S-I-N.
Yeah.
But what I'm wondering is, can we? I know she recently did a talk at the Rett UK Roadshow. Mm-hmm. Can we somehow link to that, Rob, in the chat, and then afterwards we can send that.
Yeah. I've got the link.
That would be
great.
It
might be useful.
Brilliant. Yeah,
great.
Fab.
And Julia, if you could email it to me, I can put it in the follow-up email after this. So then everyone who's signed up will get it, not just those of us who are here now.
There's another question though. How do you find a chest physio? Because I know I keep asking this, but everyone can't call Sian because she's, you know, busy, and she's also only in one person in one place. So how do people get them if you want to get one?
There will be some around that look after COPD, chronic obstructive pulmonary disorder, and also cystic fibrosis. These are the people you want because they are actually experienced in the lung part of the problem. You just need to keep doing your searches. These people are around. You just have to find them. And they might be working in different areas. They might even be working for the NHS at the local hospital, you know.
The problem is a lot of the time Yvonne and I have discussed this a number of times, that in Rett syndrome, you don't seem to get a referral to anybody about respiratory issues unless you've had a serious adverse event with respiratory stuff. And people seem to sometimes get the sort of worries about chest infections mixed up with the breathing irregularities.
The breathing irregularities. Although they are linked, though, you see, they're linked.
Of course. It's all the same apparatus.
It is, because if you're a feeble breather, our daughter is, then, you know, likelihood is you're going to have a feeble cough as well. And, you know, you've got to help that. You've got to encourage the cough. You've got to assist it. So, yeah, they are linked, but they're not the same thing. And I still cannot understand worldwide why this is not flagged up as a major problem and threat to life, and why there's not more research into it. I get very angry because I keep asking the question, and you know, we get lots of issues, gut issues and all sorts of things that come up, people are really interested in. We cannot seem to get the consultants and the researchers interested and talking together about this.
Well,
and I don't know why.
I think I'm glad you said that, and I think I read something yesterday where Sam had said something similar. Sam, would you like to elaborate on how you feel about this?
Yeah, it's we're quite lucky. We live in Leeds, so our local hospital is Leeds General, which has a specific respiratory unit for pediatrics. It's a cystic fibrosis unit primarily, but it's kitted with a lot of chest physios. Yeah. It's got a great department, fully behind the idea that without Leeds Hospital and without the team at that ward, Lillian wouldn't be here. I'd recommend for anybody that lives in a smaller town, try and get a consultant in a respiratory. If you ever get referred to one, to always look to one within a specialist like building like what we've got at Leeds. Main cities, so Alderhay have got respiratory units for anybody in the northwest. London, you've got the main children's
Royal
hospitals down there as well.
Is good.
There's places that deal with respiratory issues as a primary thing, and that's who you want to be speaking with when you do get a referral to. You want to speak with the people that know more that you can find out off of Google. You want the people that you can have a conversation with and treat you and you treat them like you're on the same level, and somebody that realizes that you know what you're talking about because you live with it day in, day out, and that you realize that they know what they're talking about because they've got the experience with the patients that are like your daughter or person that you care for. You want somebody that you can sound off opinions and that you can ask these things. Melise mentioned earlier that she's trying to get prophylactic medication. Lillian was on it for a while back, as I say, around about 2-3 years old. It stopped then when the chest issues sort of cleared themselves up, but she had such a bad issue about 5 years ago that I went to the respiratory consultant and said, you know, I feel that if we go through a winter, if she catches a cold, she catches anything goes on her chest, she's not going to make it out a winter. He suggested prophylactics, which is what I was hinting at. He wrote up a prescription, got it straight through to the doctors, and I can have as much prophylactic medication as I want. And I can change
so hold on a minute. Can you just explain what is prophylactic medication?
Yeah. So it's given a preventative course of antibiotics. Based on the person's weight and age, you generally give them a certain amount of medication, but for a prophylactic, you give her a lower amount of medication. So it's enough to sort of tick over in the system, but it's not as much as you would give to treat an active infection. Generally, you won't incur the side effects such as loose bowels or anything like that with it as well. You're just sort of preventing the early stage of the infection coming in. It helps a lot for us anyway. My personal experience with Lillian, whenever she's not got it, because she runs out of it sometimes when the like bank holidays and things, or we can't get hold of a prescription at the chemist. You can see a difference within 48 hours that the chest rattles start again. You can hear these kind of things. So even 5 years on, you know, it's worth having these kind of things, and I'd recommend it to anybody that has a lot of chest issues to investigate it and consider whether it's appropriate for yourself.
Yeah, this is one thing I was going to ask. So for people who are watching or listening whose children aren't necessarily having a lot of chest infections and haven't had a serious event, who would go on this preventative med? At what point would you go on it?
My personal opinion would be, I thought at the time, she'd had glandular fever and she'd been in hospital for about 5 weeks, and it had absolutely drained her. It's bad enough in an adult, obviously, if anybody has ever had it. But Lillian was so ill at the time. I've seen her ill, and I've never seen her as ill as she was with that. And it was when we did the follow-up from that, because she ended up with so many chest issues because of it, that I discussed this and started it. It wasn't necessarily a chest infection that had caused me to say it, but the glandular fever had hit her so hard, and other issues over the past had hit her so hard that it seemed worth asking about it. I'd say if you're starting out with chest issues and you've had chest infection once over a winter, then it's the first winter that things have been a bit iffy for you. You know, ask, maybe see what people think.
Yeah.
You don't need to pressure about it, probably, but if you're seeing infection after infection after infection, especially if it's over a relatively short period of time, ask, push then if you need to. And I'm not shy about pushing the doctor for an opinion. If I say that I think that she needs a medication, I'll ask them, I'll do my research, and I'll go in armed to the teeth with everything, and they'll agree to it pretty much straight away as soon as I mention it, without even needing to question anything deeper. But
I think I just asked the open question because Claire has a respiratory consultant as well, who actually admits that she's at the end of her knowledge, doesn't understand Rett syndrome, and she doesn't deal with many people like Claire. So
it's familiar.
We have been elsewhere, which is what we got a referral to the Royal Brompton in London, but it was only remote, one of these remote things. But we just asked, is there anything more that could be done? That was the question. And the answer came back, well, you can take a preventative, a prophylactic antibiotic. And so we said, we'll give that a try. And Claire does have that 3 times a week.
Yeah.
I think it's azithromycin. Is that the one? I get them muddled up with the one she takes for, I think it is.
Yeah. We, sorry.
Sam, yes, go on.
We use coamoxiclav, so it's
Claire's become allergic to penicillin over the years. That's another thing to be aware of, unfortunately. Yeah. I mean, she's now, as I say, she's now 41 next week. So you do have to be careful that over the years, she's taken so much penicillin-based stuff, and actually penicillin-based is the best I understand for lung problems, lung infections, but she can't take that anymore. So, sorry,
Beth.
It's fine.
This is the problem with having a few hosts. We're all like, Beth, would you like to go? Yeah.
I was just going to move over to Melise, because there's a lot of I know Melise at the beginning talked about the prophylactics, and she also mentioned a chest physio, and it sounds like Sam's obviously on the case doing the research, as I know Melise does. Unfortunately, Sam, you say that actually that the doctors have been very receptive to your ideas and your knowledge. I was just going to see if Melise has had the same experience, and because we know that from borough to borough or geographical area, I saw Melise shaking her head. I wondered what her experience is, because not every parent will have that same receptive.
This is why we are in the process of changing consultants, because Caelan's paediatrician, all I can say is he lets his ego get in the way. He knows better than anybody.
Unfortunate.
And that goes way, way back to before Caelan's diagnosis, really. But yes, so Caelan, the first time she's had chest physio was in October, when we were in hospital with the seizures, dystonia, because she still had the chest infection. That is the first time, and she was in HDU as well. So that is the first time we have ever had chest physio. It was not offered after we left hospital. Obviously, by the time we did leave, the chest infection had cleared, our chest was clear, which was great, but it was never sort of mentioned as an ongoing. Caelan does have physiotherapy at school. They are based in school, which is great, but they are not actual chest physiotherapists. No. They do know the moves. So yeah, they can do it. But no, and as obviously we've never, if I hadn't, it was actually Kaylin school nurse, sorry, that mentioned about the I can't say it.
Prophylactic.
That's it. Antibiotics to us, like after her admission in October. She said, why isn't she having these? Because she is having a chest infection every year, round about the same time. We know the sort of timeline. You know, for so many months, she could have these antibiotics to hopefully prevent this, because obviously they do seem to be escalating. Obviously, it was the 2.5 years ago we found out she needed oxygen overnight. Not last year, the year before, we managed to avoid hospital because the consultant, the respiratory consultant, had said we were allowed to go up to 0.3 from 0.1 litres per minute, which she was on. If we had to go any higher than 0.3, we would need to go in. But she stuck at the 0.3, and we had obviously the antibiotics, it wasn't a clarithromycin. So we avoided hospital then. But obviously last year, things just kind of blew up. But the one sort of strange thing I found was when they were doing chest physio, when they actually turned her onto her right side, she started having a seizure, and it happened every time. So I'm not sure if they're linked. Well, like if the infection was more, but no, they said the infection was on her left, which is the side her curve is. You know, that's what makes you curve. So obviously her scoliosis is affecting her lungs. We are awaiting surgery, but COVID obviously kind of put paid to that a bit. So yes, 2 years since we made the decision that yes, we were going for surgery. We're still waiting. So obviously over that time our spinal have got worse. But yeah, so I am one for saying to the doctor what I feel Kaylin needs. I have been shot down by her now old paediatrician, when generally I will actually go to the GP and see if they will basically prescribe what I believe she needs. And a lot of time they're very good, especially one of our GPs, they're great. But as I say, we have struggled over the years to get treatments from her paediatric consultant. But when we've gone deeper into it, it's turned out that yes, my research was kind of right. She did need this treatment.
I think it's about over time, it's about you getting to know your doctor well enough that they respect you, like Sam was saying, and they listen to you as a sort of equal partner, because you do bring crucial knowledge to the situation. Can we just go to?
Could I just flag up one other? Could I just flag up one of the really important thing, Rachel, before I forget? Sometimes there are allergies here, you know, that can cause hay fever, asthma. Can you still hear me?
Yeah.
Oh, sorry, the screen went black, sorry. So one part of Claire's investigations was to do this is an NHS full allergy screening, because sometimes the coughing can actually be caused by an allergic reaction. Claire is very allergic to grass pollen, for instance, that this allergy test threw up. And so in addition to the prophylactic antibiotic, she takes an antihistamine as well, because it was found that she actually is allergic to quite a few things. And I think that must be done too, if you're seeing lung problems and coughing, because it could be overlooked.
Yeah, that's a good point. Well, one thing that I really wanted to bring up here was the Rett Disorders Alliance health checklist. So one of the things that was really good about the health checklist, we made a section on respiratory problems, and Yvonne was invited obviously to be part of this because she's got such extensive knowledge about respiratory issues, and actually advised that we split it so that, and it's on page 3 if anyone's got one, so that we split it into preventative strategies and then managing active infections.
Yeah.
So I think it would be helpful now to go through what those things are, what the key elements are, bits, adding in, first of all, what's in the health checklist, and then adding in the new things, Yvonne, that you've already added to the edit that's going on right now, which I pulled up on the screen a minute ago, and there's some
I
new
didn't
stuff
put allergy in actually, Rachel, which I should have done, shouldn't
well,
I?
let's bang that in now. We might as
Bang
well
it
work
in,
as we go.
please.
And then I would like to hear, like, if Sam and Millie's agreeing with those things, and then what else we could put in, because I think then that's the most useful stuff that can come out of this, really. So I have a copy of the health checklist in front of me, so I could just call out what there is, and then you guys can feel free to jump in and elaborate. Well, and the other point I would like to quickly make is this speaks to the whole problem overall, and the reason we wanted to do this session today. When you look in this section, there's literally 2 references for further reading. One is about pneumonia in mice, and the other one is an article written by Yvonne called "Don't Leave It to Chance."
Oh, that's right. Yeah, I'm looking
which
at that.
Rat UK published, I think, last year, or the year before. It was in the newsletter. Yeah. So that's really sad, isn't it? That there's sort of you know, there's such a lack of information about this when it's the leading cause of death in Rett syndrome.
And I've been to international conferences and nothing like this has been talked about.
Yeah, dire. So in the health checklist, it basically says prevention of chest infections is key to the longevity of patients with Rett syndrome. Early management of active infections leads to better outcomes for these patients. So one thing that we can all do is have an annual flu vaccination. It also has the Pneumovax, which is the pneumonia vaccine in there, although Yvonne's already said this doesn't stop you getting all kinds of pneumonia. It is a one-time thing as far as I understand. I think it's every 8 years or something like that. And then we have here input from respiratory consultant, which we've already established is difficult to get. And then the regular checks by specialist chest physio.
Even more difficult.
Yeah. I think
So let's
Yvonne, I could just interject. Yvonne made a point really early on, and I have just put it in the chat, that I think it's really important from a perspective in that quite often we see little children who have lots of aspirations, lots of chest infections. The solution is a peg because it says eat in their swallow, and then we forget about the secretions and the management of that. So I think it's almost not so much managing the infection, it's what Yvonne said, manage the secretions, and a peg doesn't sort of solve that problem. It can create that, I think, as well.
Well, and also the other thing is that you're not looking, that people don't necessarily add in is reflux.
Yeah.
So you can still be, you can have your peg, but you can still be refluxing and aspirating on that. I mean, let's rewind even further. Also on page 3, thank you for bringing that up, Julie. Also on page 3 is the aspiration piece. So, I mean, one thing, because I've been doing a lot of research into this the last few weeks as well, and the conversations I've had with Yvonne previously and Catherine, who is also here, who's had a serious event with her daughter. But basically to say that we're unsure if it's always aspiration that's causing chest infections. It could also be some physiological differences that make people with Rett syndrome more prone, or more likely it's a combination of issues, but nobody understands this properly yet. So what we're going to do with that? Yeah, go on.
Personal experience with that, I had a lot of arguments and discussions with a consultant, one of the very few I never got on with, who insisted that Lilianne's chest infections were always going to be the cause, were going to be because of aspiration. She once told me that she had viral pneumonia because of aspiration. She told me all kinds, and she just insisted that because it was always in the same place, lower right hand side, it was always going to be, because that's the way that aspiration would lead it to be most likely.
Lower right, sorry, did you say lower right?
Lower right, yeah, it's chronically collapsed, just like your daughter's as well.
Yes,
She, this consultant spent 3 years arguing with me that it was aspiration, explaining to me what silent aspiration was, like I didn't understand, and we kept denying that it was aspiration. We'd had multiple video fluoroscopies, we'd done the investigations into it, I observed the feeding because I was doing all of it myself basically at home, so I could see what was going on. When we did get an unsafe swallow later on, and we did start moving to an NG tube and a peg later on, the chest infections didn't change in my personal experience with Lillian, because as I believed all along, they weren't the cause, or aspiration wasn't the cause for her. I didn't think it was all along.
And they put it down to that always, don't they?
It's other people. I'm not going to say it's not going to be aspiration.
Yeah.
Anybody watching, yep, it could be
Who
aspiration.
knows?
Don't
Who
deny
knows?
it. Listen to it and check. But yeah,
who knows?
it's not as simple as it can always be aspiration. There has to be other things that work with it. It could be reflux. It could be aspirating saliva. It could be other
but
things
it could
that
be
you can't
something
control.
in the lungs of some Rett people.
Yeah, my daughter
don't know.
doesn't fully expand her lungs and contract them.
No,
She's breathe
actually, I
deeply.
want to go on to that one. I hope, can you remind me about that if I don't talk about it? We talk about preventative. We're into preventative now, and this is one of the preventative things I want to talk about.
Yeah.
Okay, about expanding lungs.
Okay.
That was one of the things.
Rachel, sorry, Dawn had her hand up. I don't know if you spotted it. Just didn't want to go without letting you speak.
I think I'm just going to say the counter argument to what you've just said, Sam. When Erin's 13 now, and when she was 2.5, for other reasons, she got diagnosed with a delayed swallow. So she still eats orally, food is fine, but no liquid. And every time we've tried to come back and reintroduce liquid, she's straight away
Chest
test
infections.
infected. So
Yeah, it's
for her, it definitely is aspiration.
the exact opposite, but it still makes sense. You know, I don't want to say to other people like yourself, don't consider that it's aspiration and consider it something else, because it can be. You know, there's so many people with Rett syndrome with aspiration, silent aspiration. Lillian aspirates on saliva as well, so that
you can.
It can be all kinds. So anybody watching should definitely consider aspiration. But when you have considered it, and when you've checked your swallow studies, and when you have got a peg and you aren't feeding by it, there is a point where you do have to consider other things as well. But always consider aspiration, because it can be serious and deadly, obviously. It's definitely
We're
something
starting to wonder,
out.
and I've been having this discussion with lots of different researchers as well, if there's fundamentally something different in the lungs of people with Rett syndrome that we just don't know about. And Yvonne brought this to me first of all. You know, but basically it's not been checked. A lot of the time we're not looking into the lungs of people with Rett syndrome, so we don't know. And there's also this thing, you know, they just have these secretions that keep thickening up. One of the things I really want to make sure we get to is things like how to, when someone starts to get a chest infection, how to keep the secretions thinner so that it doesn't deteriorate. So can we go to what do you guys do when you first start to sense there's something coming on? Can
I say that I think you really need to go right back to the start, and I think you need to have a plan. I think you shouldn't just treat this randomly. You know, you need to sit down. We should
all have a respiratory protocol for our children.
Well, I called it a plan, but a protocol. Yeah, a protocol, plan, call it whatever you like. But I think if you can sit down, and ideally with a respiratory consultant, get your GP involved, get your, if you have a chest physiotherapist, get her involved, get everybody involved to sit down and work out what you're going to do, preventative wise and active, if you know how to prevent and how to treat an active chest infection. Particularly the active chest infection, Claire has a traffic light system, you know, green, amber, red. So, and this is particularly important when people are either in respite care away from home, or they're in residential care. Even more important when they're in residential care, with all the changes of care workers and whatever, because, you know, things can happen really quickly with our Rett people. They can change really quickly. So they have to be on it. They really have to know what they're doing. And I think that to have this written plan that and a simple, you know, keep it as simple as possible. So everybody knows what to do at the various stages, really. And I think, you know, everything that we've talked about needs to come into that.
Yvonne, can I just ask, for the sake of, or Sam or Melise, for the sake of, you know, those of us who aren't dealing with these issues yet, or for someone who is maybe at the very, very start, what does the protocol look like? I mean, what is your protocol? Just so we've got an example and a model of, you know, how are you dealing with this on a preventative level, and then
right. So
I mean,
Hopefully it's a lot like what's in the health checklist.
it is, yeah. I mean, I just quickly run through use of a prophylactic antibiotic during the winter months. We use carbamazepine, which is something that you may or may not think is useful, but that keeps the secretions fluid. Back again to don't let them clog, don't let them get thick, keep them moving. That makes them easier to cough up. However, once you've got to that stage, if you've got a weak cough, then what do you do? Well, maybe you need to use a Yanker suction. Not a deep suction, but maybe you need to add in a suction machine. So another preventative, if coughing is becoming very frequent, observe and take the temperature frequently, because often our people have a low temperature. So if it starts creeping up, that's the sign possibly there's an infection coming. And if the temperature is raised, if people start to get worried, that's when you call in your chest physiotherapist or your GP. The other really important thing in preventative treatment is positioning. We haven't talked about that. I think Sam talked about molded wheelchair, which is really important, but I think positioning when feeding is crucial. You need to make sure when you're feeding your son and your daughter, you're doing it as safely as possible, that the head is positioned in the safest possible position. Now, the way I describe it, really simple to remember, is you keep your chin tucked if you can, keep it low, have something behind your head to position your head in the right position to keep it that way. It's the exact opposite from what you do to open an airway, CPR. What do you do when you put your head right back? That's the first thing you're told to do, open the airway. No, with Rett and when you're feeding, positioning. So this needs to be wherever they're sitting, particularly when feeding. Keep that body, as straight as you can and keep that chin tucked in. So position is really important. And keep on top of that mucus clearance is a preventative thing. And I think I did talk about devices called the vest, and also something we call an LVR bag, which is a lung volume recruitment bag, which is a bag that we use with Claire once, sometimes more often a day, which helps expand her lungs. It's very non-invasive, it's pretty safe, and it helps expand those lungs. That's what you've got to try and do. You've got to try and stretch the lungs.
Yeah, when you said stretching the lungs earlier, I was a bit like, what?
Well, I mean, actually, I picked that up from Sian's details, but yeah, you know what I'm expand. I mean, get the best capacity. Because what happens often with the Rett people, their lungs get squashed through scoliosis or through other things, and you want to try and get them, you want to get the air into them, It's all pretty basic stuff, really. It's what you and I are doing because we're exercising, we're moving around. Our guys are not necessarily able to do that.
I think, can I, Rachel, I haven't got the health checklist in front of me. Can I ask, are there links in there to things regarding like the kind of equipment that Yvonne's talking about?
Well, they're not in there, no, and that would be helpful. So we'll do that on the next edit.
Can I quickly talk about the vest, because the link needs to go. It's by the company called Hill-Rom, HILL-ROM, very big medical company. When Claire was really ill 2 years ago, when she almost died of pneumonia and sepsis, I put out a call, and thank goodness for the Rett population, to the American, well, I think it was the International Rett Parents Link, and said, look, our daughter's got these dreadful secretions. What are we going to do? We're getting desperate. And coming back from the States, not from the UK, was, we use something called the vest. And we used it a lot. And you see, it's a very expensive piece of equipment, I have to tell you, very expensive. But it's very effective, certainly for Claire. She uses it twice a day for 10 minutes each time. And it's a virtual physiotherapist. It vibrates the sides of her lungs. and hopefully keeps those secretions moving. She uses it twice a day, and she uses the vest as the LVR bag as well, once a day or twice a day, up to 4 times a day. It's quite big stuff. It takes quite a lot of your day. This is the big problem, of course, you know, but
7,000.
but it's really good. But the vest is used mainly by people with cystic fibrosis. That's where you'll find it.
And I did find as well that it is funded for some people through the NHS.
It could, well, did we get ours funded or not? I think we couldn't wait, actually.
And potentially you could get something like that through your PHC funding as well. You could, but there's always a delay, Rachel. It depends how desperate you are. We were pretty desperate. So, but they do give the opportunity to try it out. You can trial it, I think, for 2 weeks. I think it's about £6,000 from what I remember.
Yeah,
when I looked.
something like that. Yeah.
Yeah.
But I think we need to put the links to these into the health checklist. But I think that it's helpful to say, just to clarify, we've been talking obviously about mainly about people who have been very seriously ill with chest infections. And obviously there are lots of different people with Rett syndrome of different ages, and some of them have chest infections and some haven't yet. It seems to me like anything can always pop up at any time, so that you can never kind of go, I'm safe now from that. I think for people who are younger, even though we've been discussing the fact that it isn't always about an unsafe swallow, that someone is having regular chest infections, even though we don't necessarily yet know why. We are seeing some emerging information that says that there are abnormalities, structural abnormalities in the lungs of some Rett patients. So there's that. But I think the key thing that you can do, even though you're not going to ever say this is definitely what's causing chest infections, you still, if you're someone's child isn't having chest infections or just has them sometimes, still really look at the aspiration information, because that's just so key, that people are upright as possible when they're eating, that they'd do the chin tuck. We have an aspiration fact sheet on the Reverse Rett website, which we can share as well, that I think also probably needs updating. Mental note that we need to update that, but because we could add some of the stuff like the vest onto there as well. But I think that has links to how to do a chin tuck and so on. And also one other thing I think I picked up when Amber was having some chest infections the last few years was to keep the secretions thin. And this is a simple, ridiculous thing, not that helpful, because obviously you guys have dealt with really serious stuff and she actually hasn't ever been hospitalized. But just to increase her fluid uptake massively when she starts to get chest infection seems to thin things out for her, and just keep it up as possible.
Yeah, I mean, when Claire was seriously ill, prior to that, she hadn't had a peg fitted. She was eating orally. So things changed dramatically at that point. But I think that she did become dehydrated. And I think that's really quite, well, I know it's really dangerous, because it was explained to me that unless you keep somebody really well hydrated and also good nutrition, the antibiotics are not going to work well. And so,
you know what, Yvonne, sorry, go on.
And so the other reassuring thing is she managed without a peg for 39 years. She has managed for 39 years with with pretty residual scoliosis and all her other problems. So it was only then that she had the peg fitted.
There's
another thing that
after you, Rachel.
That was all of us at the same time. Go, Julie.
Go. A couple of things that I think, if I can remember them, because I've got one of those brains, it's quite often I hear families who our children are fed and they're sort of prescribed water, sort of 800 ml a day, and they think that's great, and yet mainstream everywhere you go, it's a litre or 2 litres a day, and it makes me wonder why is this theory behind you flush with someone who's peg fed and then you give them 150 mils? Why aren't we pushing for those 2 litres a day for people who are peg fed? Why is that's a question, I guess, rhetorical maybe, but you know, why if we're all being encouraged to drink as much water as we possibly can?
It's really important because
Yeah,
the
so
dry,
why
like
is
having a dry
800?
mouth can make
Yeah.
you start getting a cough as well,
Yeah.
can't it?
Yes,
Yeah.
And so I think
And-
I question that 800 mils. Is that enough, or you know, clearly not.
Yeah, actually, you just
Yeah.
raised something that I may have forgotten. Mouth hygiene, oral hygiene. Rachel, did I put that in my? Because it needs to go there.
I'll look right now. Carry on.
Preventative, please, preventative, because another friend of mine whose daughter has something else, she was told that one of the causes of pneumonia can often be because you're allowing the bacteria in the mouth, and particularly if somebody is peg fed, totally peg fed, you need to keep the mouth really, really clean. So mouth hygiene, oral hygiene, in terms of clearing any of the nasty gunge and secretions that sometimes get there. And also it's much nicer for somebody to have a moist mouth and a clean mouth. I mean, Claire positively smiles when I do her teeth. I have to be really once again, you have to be really careful. You know, we do it with just water first of all, and then very, very gently put the Durafat toothpaste, just very, very gentle, and only a very, very small amount, because that can cause choking as well, foaming.
And also another thing, sorry, Beth.
I was just going to say, I think what's really interesting is that obviously apart, you know, we're putting aside things like a £6,000 vest and equipment like this, a lot of these things are very, very simple.
Yes.
A lot of these
Yes,
preventative measures are simple things that even those, you know, touching where I'm fortunate Hannah has not so far suffered with chest infections, but as Rachel said, everything is around the corner, that all of us can be doing. That are very simple things in daily life to just try and
preventative stuff.
Yeah. I wanted to just go over to Melissa and Sam and ask them about their preventative measures. If there's, you know, obviously if they're in agreement with Yvonne, if there's anything else that they found that works, and also what are those, you know, those trigger moments for you where you go, okay, look, right now we have to spring into action here. What's that trigger moment that you take notice of?
Well, for Kaylin, it's her chest infections start very quickly. We actually don't really get much of a warning. The last one, for example, she came home from school one day. She'd gone to school absolutely perfectly well in the morning, come home from school and was coughing. Well, obviously our first thought last year is COVID. So we took her for the test. But even before we got the results back from that, the next day I took her up to get her checked on the Children's Assessment Board, where we've got direct access, because her chest had gone really chesty, and I'm not sure it's COVID. So yeah, but obviously she had to have another one. But yes, this is it, that from the morning to coming home from school,
it can
never said anything that there was a problem. So for Kaylin, it does come on very quick, and our first stop is get the chest checked, because obviously we don't want to assume it's just a cough or a cold, because normally it's not. It's never just a cold with Kaylin. It normally does go on our chest. So preventive wise, at the moment we have not much of a plan, because it does just kind of happen. But she has a pea pod that's molded to her, and as soon as chest infection starts, she doesn't sleep in her bed. She sleeps in her pea pod, because she is so much more upright. Now, don't get me wrong, she has a profile in bed, so the head end can raise. She actually has a fully molded sleep system as well, but she doesn't sit up well in bed. She tends to slide down. So the pea pod is the best option, because we can have her so much more upright, but she's still really comfortable. And yeah, I will be downstairs on the settee overnight with her, just to obviously keep an eye on her, checking sats and things. So that we've not really got a preventative plan, but hopefully we will have once we speak to a consultant. But Yvonne's ideas, like I'm liking them. I would never really thought even about toothpaste and things, to be honest. Kaylin hates getting her teeth brushed, so it's a fight to get it in there. And yes, if I use my finger, she will bite. She will definitely
Actually,
bite.
if you have a suction machine, you can get toothbrushes specially made, especially to go on the suction machine, which actually suck out the the secretions and the nastiness. So you can get those as well. Special toothbrushes.
Yeah, suction machine is going to be something else, I think, on our list, because
you need that needs proper training. You can get that funded, obviously, but everybody needs to be trained to use that. It's only anchor suction, it's not deep suction.
Yeah,
it's
that's
only
what
suction along the lines of the back of the mouth to follow the tooth to the back. But often you can you can get the stuff that's accumulating there.
Well, I ended up obviously I wasn't actually trained, but when she was in hospital I ended up using the yanker. Obviously the nurse was there, but she was maybe recording the seizure or just on a episode at a time, and I would get it there.
Happy days. Another of the lovely skills you get along the way. It's amazing, isn't it?
It's a terrible name as well, the yanker. Gosh.
Just one thing with regards to raising the bed that Professor Warwell, who's the gastroenterologist, was saying, and which I guess I hadn't thought about, in terms of when you raise a profile in bed, what you're doing is actually, I don't know if you can see, is you're cutting the body in half. So although you're raising it up, you're squashing the gut further down. So what he's actually saying is raise the feet of the bed so the whole bed is on a slant rather than just the top half. Did that make sense?
So you've got your head lower.
I know what you mean.
So the whole bed is raised at that angle rather than just the top half, so you don't get that block in the gut in the middle.
So you lower the feet.
I don't know if you can see.
For me, the problem there on a practical level is Amber always, she's so
on top of the bed.
It's definitely something that he mentioned. So if you're sitting somebody upright to reduce sort of reflux and that sort of thing, but you're folding them then in the middle, his point was raise it as just the end of the bed, like the foot of the bed, rather than the actual mattress part. Do you understand what I mean? I'll draw it. I'll explain it.
Draw us a picture. That would be perfect.
I'll see what I can do.
You mean to tilt it, don't you? So you're actually tilting the base.
That's it. Thank you, Louise.
Well,
That's exactly what I meant. I couldn't explain it. Yes.
The feet go down, in fact, not
possibly.
The whole bed is on an angle.
Yes. So you're not. Thank you, Louise.
But
I don't understand, so I need a drawing, please.
I need a drawing. I don't understand either, and also I just don't know how I would stop her from. She has a good sleep system.
George's bed, you know how it can go up and down if you've got a profile in bed. There's a button so you can actually tilt so that where it goes up and down, just the up will come up at one end, so the whole bed will be slightly angled, so on the actual frame will tilt, so the mattress doesn't move, the actual frame of the bed will tilt. There'll be a button on your controls.
I get that, but the thing is, with the sort of angle that I need for Amber, she'd be tilted so much that she'd go So I normally, with her bed, I press the button where the whole thing comes up, like, the back comes up and then this little bit comes up here.
So
something to her knees, and then so she's curled like that. But I totally agree about the gastro issues. It's just that as always,
the problem is you solve one thing and you get another, don't you? You're solving one thing and you're causing a problem with the other.
So you have to prioritize which thing is
which is most important today. Is it tummy or is it chest?
More risky.
Rachel.
Well, we've kind of gone very over time, Beth, and I think we should just acknowledge that because it's 12:20.
We should. I did want to just go back to Sam and ask him the same question as Melise.
Okay, go on.
I mean, obviously, if anyone needs to go, then the whole session is being recorded. We're still recording, so when you receive that link, it will be the full recording. But if we could just pop back to Sam and ask them also about their obviously you've been dealing with this a long time as well, so your preventative measures and your trigger moments, and I guess really if we're kind of trying to sum up, it's that kind of take-home message. What's the key thing? What's the one thing you would say to other parents?
We're somewhere between Yvonne and Melise with this one. I've got a plan, but I don't refer to it because it's not always relevant to do it. Lillian's quite a scary example probably for this one, so she's probably not the norm, so don't be scared off listening to it. But she can desat really quickly. The last time she went into hospital with an issue was my birthday on the end of February. Woke up fine, did my birthday presents fine. She sat down watching the TV fine. 2 o'clock in the afternoon, she started rattling a little bit in her chest. By 3 o'clock in the afternoon, she was on 5 litres of oxygen and non-invasive ventilation. We are kitted like a mini hospital ward in the house. She uses BiPAP overnight and oxygen, and she's authorised to use up to 5 litres to keep her at home instead of in the hospital, because we've had a lot of experience with it. Most people won't go anywhere near that at home levels. So as I said, she's an extreme. We kept her at home overnight because trying to get her admitted into the ward that we needed to be into at night time is really difficult. Your best time to get her in is the day. We know this from experience. I hooked up a mobile concentrator that we bought with the other concentrator that we already got through the NHS. So she had 7 litres worth of oxygen going to her instead of the 5 that she should have had, just to try and see her through the night. And we kept her at levels at sort of 90 in her SATs, which are below what anybody else would be at. But Lillian's experience of this, she can handle a lot better than anybody else. So yeah, hers is a scary example. She ended up in the hospital the next day, and then spent a week and a half, nearly 2 weeks in the hospital with that one. Generally, what she's supposed to do is we're supposed to be able to manage it with the 5 litres, either daytime or nighttime, using the non-invasive ventilation at nighttime as well. The hospital will accept her in then if it gets to the point where we can't manage her, but it goes so quick sometimes that you can't do that, and then other times it sort of lingers just before that, and you consider whether you should or shouldn't. So there's a lot of judgment with Lillian's, which is why we can't always refer to the plan straight away, really. As soon as I see there's a problem, I'll put her antibiotics up from the prophylactic dose that she's on. So she has 5 mils twice a day for her weight with the strength that she's on, and I'll put it up to 10 mils 3 times a day, so that she's getting like a good hit of antibiotics before she goes in the hospital. If she doesn't, then we just go and get another prescription for it, carry on with this for a few days, and make decisions as we need to. She generally, there's a lot of times where we've had her at home for a couple of weeks on end with using ventilation near enough 24 hours a day. All the other bits and pieces that go with that, you're having to take her from the bedroom to the living room hooked up to oxygen, but the concentrator that's mobile will only do 2 litres, whereas the other one will do 5, but you have to turn it off to go between rooms. So you'll have a lot of alarms beeping at you very suddenly, and a lot of numbers that you don't want to be seeing on an oximeter. If you can push, if you're having respiratory issues, if you can push to get an oximeter, nag the life out of somebody to do it, because it's a real big thing. We were warned so many times that it's something that it's not going to affect her treatment. It's something that we don't need to be monitoring, and most parents are going to be obsessive over it. It's not that. It's when you know that something's not going right, you need to know how bad it is rather than obsessing over it when things are right, which is what they were kind of getting at with me. So you can buy little finger ones, no problem, off Amazon, Boots, anywhere like that nowadays. They were harder a few years ago, but £5-6 to keep one in a bag. If you take a bag out with anywhere like a feeding bag or anything, just on the off chance that anything doesn't look right, it's a peace of mind thing more than anything. Use that and just check, and if you can, nag at somebody to try and get a proper hospital style oximeter, because they've got the budgets within the community healthcare to do it. It won't be personally yours. You'll have to have it sort of swapped over, serviced and everything every year, whatever. But you've got access to it. You'll be able to use it as much as you need to. It'll give you a peace of mind that when you go to sleep, that your daughter or anybody that you're caring for is breathing sufficiently and her SATs are still all right. And if they're not, you'll get an alarm and it'll wake you up. It's a massive peace of mind thing when you do need it, and it's something hugely I'd recommend. It took us a long time of getting that one. Ironically, the day that we got the first one, she ended up in hospital 2 hours later because she had a chest infection, which is what happens a lot with Lillian. So yeah, her care plan is weird. We've got open access again to go into the hospital. It was a children's assessment unit, which in Leeds is based above the A&E entrance, but that's been changed now because she crashed so quickly. They'd rather she go into A&E instead, so we've got access to A&E. But if you've ever been in a normal A&E department, they're not kitted out for children in wheelchairs, so it's not a great solution. Yeah, we've got this plan made by the ventilation nurses, so they sort of sign it off and adjust things as needs to be. But you probably want to find yourself something that works and be comfortable that you know what's going to work. You know, deal with the people that you're dealing with, sound off ideas, agree things, but understand as well that sometimes you've got to go away from your plan when you think that you need to. And if you think that your daughter needs to get into hospital, even if you're not quite at whatever level that you're supposed to be at, you know, do it, because it's a lot better. We live 30 minutes on a blue light from the hospital. I've drove it when she's been desatting in the back of the car, and it's scary. It's quicker for me to get her to hospital sometimes than to phone up and wait for an ambulance to come out with where we live and then to drive her to the same hospital. With having a lot of access to oxygen, we've got some of the equipment that they can do. So sometimes that stupid decisions like that need to be done, whereas you think an ambulance will be able to treat somebody better, but it's not always the situation in my circumstance. In most people's it's going to be, but with the distance that we live, you need to consider the urgency of what can happen. And when she goes downhill so quickly, those decisions can be really important. As I said, she's used to dealing with low oxygen SATs and things like that as well. But on my birthday, she ended up down at the 60s within the space of an hour of being healthy, from presenting as healthy and knowing what I'm looking for to being that bad. And you've got to be comfortable with what you're doing, I think, is the main thing if you're ever considering a plan, and understand like how you're getting that person to hospital. If it's going to be an ambulance, if you're going to take them in yourself, probably going to be an ambulance for everybody. Understand when you need to call that ambulance, understand what you're going to do when the ambulance comes, because somebody's got to go in with the daughter, so mother, father, brother, or whoever's old enough, whatever's going to need to go in, and somebody's going to have to stay home. You're going to need to pop a bag together and all those kind of things. The bits that you don't generally think about that's not on a plan, you need to have all your equipment together ready, your medicines that you're not going to have in the hospital. So Lillian uses sleeping medication, you need to have that ready packed, stuff like that as well. You've got to throw all this together while you're trying to deal with her desatting, trying to keep an eye on her being okay, trying to call an ambulance, trying to make sure all of this is all right, and still sort everything out for within 10 minutes or whatever they turn up.
And to presumably also figure out what you're going to do with the other 4 children.
Yeah, it's obviously me and Faye, so mum and dad both live together in the house. So generally Faye doesn't drive, so she goes in with Lillian. So I take the boys to school the next day still, because even with what she's doing, we still need to get them into school for an education. So we still send them in the next day as long as they've got a school that next day. So even if it's 2 o'clock in the morning and we're on a blue light to the hospital or wherever, you know, they wake up, where's Lillian? She's in hospital. It's happened a few times. You need to consider things like if your daughter's in a wheelchair as well, they're going to put her in the back of an ambulance on a bed rather than in a wheelchair.
No wheelchair.
They won't have access for that, which the first time that one occurred to me was a bit of a weird one. So like carrying her out obviously she's hoisted in the house, but getting a hospital, a stretcher out of the back of an ambulance into the house and things like that, you need to consider, will it come into your house? If not, you've got to lift her from a wheelchair into the bed in the garden, or, you know, just outside an ambulance, things like that, that you want to sort of plan, because if you think about it in your mind, I think you can deal with it a lot better when it actually occurs. You'll be more prepared for it, and you can just do it like as a snap, and you don't need to think about it anymore, and you can remain calmer and be more responsible for everybody in the house that you're dealing with.
That's not even just a respiratory issue though, is it? Because
it's all
obviously
kinds, yeah.
people
I mean,
go into hospital for lots of different reasons on emergencies, don't they?
Yeah.
We find that Claire's more comfortable and safer in her wheelchair, and in a good position actually for breathing. So we have to have somebody bring in the wheelchair to the hospital, really A&E, really quickly, because often they don't have hoists there. It's amazing.
No,
they have to look around.
Thankfully with the big hospital we've got them now.
We're not Leeds, we're Worcester Royal.
We I think that's one thing of having a big access.
You're right. You need to think about these things so you're not panicking. I mean, we're lucky. We have a really good neighbour who, you know, will drive Claire's car with a wheelchair in the back and follow us. But you have to think about how you're going to do it.
Yeah, these aren't part of an official plan. I don't think anything like the random bits I've just mentioned won't be in.
Certainly, they're not in her written plan, but they're in our, you know.
Yeah, it's what you know you need to do as a parent. But
the problem is, if you've done it once, you've had sort of like a dry run, and you realise where all the pinch points are. You can sit down and think about it afterwards.
Yeah, that's a very good point. And nothing teaches you like experience.
No, but just write it down and remember it.
Which is why we
that's, you know, those situations is where things like the hospital passport are really critical, because, you know, when you're panicking and you've got the other kids to deal with, and you've got all these practical things to cope with, and knowing that we have all of those documents. We haven't always, but basically since COVID started, we have a pile of those kind of documents just by the door, that are literally, we can grab them on our way out if we need to. All those documents that we put in place at the start of COVID, including the hospital passport, which, you know, has to be updated now and then, just so it's relevant. But knowing that when you get to the hospital, you can hand that over, and somebody will have all the information they need about your daughter's history. Hopefully, they're still going to ask you a million questions that you've answered.
They need the medication. I find that's the key as well. They want to know exactly what medication and the dosage, don't they? That's the really important. If they don't read anything else, that's the thing.
And which obviously, sorry, a lot of us have that off the top of our head, but you can actually ask your GP for a copy of the Mars sheet, and then that's just all the meds and what the doses are. That you could have by the front door, as Beth's saying, and just take it.
I mean, I have it on the top of my head, but I realised when we went to Great Ormond Street recently, and I had to drop the boys off and then catch up with Vincent, who had already arrived with my daughter. He didn't have the medication off the top of his head.
No.
He was like, "Oh, what's that one called that we give them?" Like,
exactly.
Okay, I can battle them all off, but he, not necessarily anyone who turns up at the hospital can. So
no, my husband handles the medication. He rattles it off, and I don't. So we each have our own responsibilities, you see.
Absolutely.
It helps to have stuff on paper in case anything happens to you as well.
Absolutely.
Well,
we've
every time you get a prescription, we always they give you a sheet that has all of the drugs that she has on prescription on it, regardless of what you're getting. So that's always handy to keep your most recent one.
Yeah, that's really a good idea, actually. So we've gone on over time, but I think it's been an all-round super helpful session, and there's loads of resources that have come out of this that we need to embed into the thank you for coming note, so that everyone can get those moving forward. I want to thank the three brilliant panelists, Yvonne, Sam and Melise, whose hard-wrought experience has delivered so much information to us all, and hopefully got everyone thinking about actions they can take to keep their person as well as possible. I want to thank Julie and Rob and all of Rett UK, and Yvonne is part of Rett UK. You are the president of Rett. Are you a lifelong president, aren't you, of Rett UK?
I think so. Yeah, I think
Something like
so.
that. Yeah.
Yeah.
So we acknowledging that, you know, thank you very much for being willing to be part of this session.
Great
and
collaboration, though. It's what should be happening.
well, I think maybe it's something we can do again, you know,
I would
because I
hope
think
so.
it reinforces the important health messages,
Yeah.
that same messages are coming from both groups.
Rett syndrome is the same the world over, whoever you are, wherever you live, you know.
Yeah. So we this is the last actual reverse Rett bite-sized session for this summer, and I think we're starting again in September. We have a few topics in mind, but we're open to suggestions for things that people would like to have covered. So please email Beth with your suggestions, beth@reverserett.org.uk, and don't forget to fill out the feedback form. It does just take a minute, but it's really helpful for us in terms of planning. So thank you everyone for being here. Hope you all have a great day, and that everyone stays well.